السلام عليكم. أنا خالد داوي طبيب امتياز من جامعة الملك عبد العزيز. Today my poster is a combination between two specialties, obstetrics and gynecology and urology. In general, before I speak about my case, it's about extrauterine migration of a displaced IUD, and in this specific case, led to bladder wall perforation. So, in brief, IUDs, and it's a common form of contraception. It's feasible, economical. It gives good results, and it's long-lasting. Its usage has increased in the past years. However, it doesn't come without any complications. Some of the rare or more serious complications are perforation. It perforates into any of the adjacent organs, including omentum, bladder, sigmoid colon, and peritoneum. The least common is bladder. So once the ID has perforated into the bladder, it starts to the patient was going to start to complain of symptoms of lower urinary tract symptoms, including frequency, urgency, terminal dribbling, feeling of incomplete evacuation, and is going to visit either the gynecology clinic or urology. In our case, she's a 54-year-old female. She's had a long history of around 2 years complaining of recurrent UTIs, persistent, non-resolving, regardless of antibiotic usage. One thing in her history, she had a IUD placed 28 years ago after her third child. After her IUD insertion, she got pregnant 7 times after. She did not at any point think to ask about the status of her IUD. She lived in faraway rural areas, so she just let the pregnancies be. She carried all the babies to term, had a normal vaginal delivery. When she came to our clinic, she complained of specifically dysuria and urgency. So we sent her for an ultrasound. We wanted to check bladder capacity, post-void, residual, and this was the initial ultrasound finding. This is the IUD. At the beginning, the report said an echogenic structure with posterior acoustic shadowing. They did not specify that it could be an IUD. But we sent her, so our first impression was stone. So we sent her for a CT before we went for lithotripsy and removal. The CT showed very clearly, and through imaging scans, an IUD that had a very thick wall. So it led us to the impression that it's an encrusted IUD. So stone has formed around the IUD. But we told her that in this case, and according to the literature, it has to be removed. So we gave her 2 options. It could either be removed endoscopically or through open surgery. Endoscopically, we told her it could take many sessions until we fragment all the pieces, remove each piece one by one, then we have to remove the IUD itself. Or we can go through an open cystolithotomy, so an opening in the abdominal wall into the anterior wall of the bladder and removal of the IUD in 1 session. She opted for that. We went for it. It was an insignificant procedure. She recovered well. On follow-up 1 week, and then 1 month later, the patient reported almost symptoms resolved. No more UTIs, no more dysuria. All of her urinary symptoms disappeared. But that's our case in brief. To conclude, the WHO, CDC, all the literature recommends the removal of any displaced IUD. So regardless of symptomatology or location, any displaced IUD has to be removed. And something for us as physicians and to develop, if a patient with a history of IUD placement presents to your clinic complaining of chronic symptoms of urinary irritative symptoms in terms of dysuria and things, always try to ask them, how do you check about the status of your IUD? Is your IUD placed in the right place? Get an ultrasound, make sure and confirm IUD placement. If the IUD is not in its right place, always think that it could have migrated elsewhere and try to approach her in that terms. This is very true. This is the procedure that we went through, and then this is the IUD once it was retrieved, and you can see the heavy incrustations around it.
And was it sticking to the wall, obviously?
No, it was free
floating.
Okay,
and it did not have any part that actually is bulging out of the wall of the bladder itself.
No, it was complete transmural perforation. Yes, complete transmural perforation.
But do you really think of migration? Do you really consider it as a common option? Because I think most of the cases...
No, it's not common at all. From the literature, I found 40 cases within the last 20 years, but it's not as common.
And the lady had normal deliveries?
Normal deliveries, vaginal deliveries, yes.
So, very interesting. But, talking from the research perspective, I would love to hear from you more about the methodology itself. So I know it's a straightforward case report, but it's nice also to show us how you think or you convinced that this is really a case which can be a case report. So part of it would always love to hear about your literature review about this. This is what you mentioned at the end when we asked you, like only 40 cases were reported, and a thorough literature review was done, and we found there is few cases, and then how is the process of the methodology itself done. But otherwise, it's a very interesting case.
The 40 cases were migration to the bladder or to the bowel or both?
IUD migration in general. IUD migration in general to all organs.
Only 40? This is what you find in
For the past
literature.
10 to 15 years.
10 to 15 years. It's a very rare. So what is your recommendation if a patient comes to you in the clinic and she had the IUCD in place for more than 5 years? طبعا أكبر يعني معظم ال IUCDs 5 years. إذا واحدة جاتك قالت لك إن ال IUCD أكثر من 5 سنين, you examine her and the IUCD in its place. What would you advise?
And she has lower urinary tract symptoms.
لا,
She's fine. She has
in general,
IUD,
she has IUD.
she's not complaining.
And she's not complaining. والله.
From the literature that you're
I did not pass by this specifically, but mostly على physiology side, but gynecology side, what would you recommend for her to remove it?
It's okay. أنا بس بسأل. It's okay.
Thank you.